Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is colposcopy and diagnosis of pre-invasive cervical lesions, that is CIA. Historical aspect as far as this pre-invasive cervical lesions goes, in 1947, it was for the first time identified that there is an entity as pre-invasive cervical lesion. It was labeled as dysplasia and carcinoma in situ for the severe form. Dysplasia was usually treated by cryo, whereas for carcinoma of in situ, hysterectomy was performed. Richard in 1968, for the first time, given the terminology as cervical intraepithelial neoplasia or CIN for the pre-invasive cervical lesions, and even graded it as CIN 1, 2 and 3 as a continuation of the change, pre-invasive change, if remaining untreated for many years, may go through these phases and ultimately can go for the invasive cancer. This is just a revision we all know since our undergraduate days that there are three types of cervical intraepithelial neoplasia, CIN1, 2, and 3. CIN1, when it affects only the lower one-third of the epithelium, that is, in this case, it is the squamous epithelium which is present at the transformation zone. CIN2 is when it affects more than one-third, lower one-third, but up to the two-third, lower two-third. So from more than lower one-third, but it is less than lower two-third. And CIN3 is when more than lower two-third of the epithelium is affected by the changes of CIN or cervical intraepithelial neoplasia. CIN, remember that it is always a histopathological diagnosis. You should never call it as CIN based only on cervical, cytology or HPV. That is what I mean by that, or even by BI, whatever test we are doing. All those tests are screening tests, and confirmation of the disease is based on taking a biopsy and examining it under the microscope, and that histopathologist will be giving us the diagnosis of cervical intraepithelial neoplasia. So it needs a biopsy. There are four histopathological features of CIN that we should remember as important point: cellular immaturity, cellular disorganization, nuclear abnormality, and increased mitotic activity. Now, if we look at the anatomy of the cervix from the point of view of this development of CIN, important points in the anatomy are we have ectocervix, which is lined by squamous epithelium, and we have endocervix, which has columnar epithelium. Squamous epithelium has 4 layers, whereas columnar epithelium is a single layered epithelium. There are 4 layers, which are superficial cells, intermediate cells, parabasal cells, and basal cells. Parabasal cells are the reserve cells which are involved in squamous metaplasia. Columnar epithelium, it is a single layer, but it is arranged, cervical columnar epithelium is arranged in such a fashion that there are many ridges and clefts. So the upper part is ridges, whereas the lower one, depths, are the clefts, and some ingrowing is also there. So ingrowths, ridges, and clefts are the terminologies which are used whenever we are describing the columnar epithelium of the cervix. It is not there are no glands there. There are no cervical gland, endocervical glands. To call it as glands is a misnomer. These are actually the clefts which are formed like it is a single. Suppose we have a in electric wire. So what will be happening sometimes if it is too longish, it will be getting folded on itself. So there will be infoldings, there will be ridges, and there will be clefts. That is how similarly this endocervical columnar epithelium is arranged. And these are the clefts. These are actually not the glands which are there. So if we say endocervical glands, it is a misnomer. Remember that correct terminology is endocervical clefts. Whenever there is a squamous metaplasia, the endocervical epithelium is being replaced by the squamous epithelium. So a single layer is getting replaced by the four-layered epithelium. When this squamous metaplasia occurs, it starts at the ridges or the top part, and then gradually it goes to the clefts. But sometimes what is happening is when it reaches to a certain level of the clefts, then there is blockage of this cleft and there is no further change of the columnar epithelium to squamous. There are some columnar cells which are still there, which have not undergone the squamous metaplasia. They do remain at the depth of the cleft, the lowest portion of the cleft, and these trapped columnar cells are mucus secreting, and the collection of this mucus leads to the development of Nabothian cyst. You must have seen Nabothian cyst on the ectocervix, and we always say that Nabothian cysts are absolutely benign. What they indicate is they indicate that there is a mature transformation zone. That means the transformation zone process has reached to a point where even these clefts are also getting converted from columnar into the squamous epithelium. Sometimes what is happening is this whole of the cleft, the epithelium is getting changed to squamous, but only one opening remains at the top. There is no complete block of the cleft. There is some cavity which remains inside, and this is, if we look at the cervix from above, it looks like a cleft opening. If we are looking at the ectocervix with say with a good light or a colposcope under slight magnification, what we observe is there are cleft openings and there are Nabothian cysts. Both these are the features which are seen in a normal cervix, and they are suggestive of a mature transformation zone. We have already seen in the last class, but just a revision for the what is transformation zone is. It is the blue region between the original squamocolumnar junction, which is at the periphery, and towards the center we have the, excuse me, we have the new advancing squamocolumnar junction. This advancing squamocolumnar junction is very active. And it is always, there are maximum cellular changes which are happening at the advancing squamocolumnar junction. And active metaplasia is taking place, which is nearer the squamocolumnar junction, which is nearer the external os. This active metaplasia is more profound immediately after menarche, when there is hyperestrogenism and there is a sudden change in the this hyperplasia of the columnar epithelium, which is resulting in the shift of squamocolumnar junction to original squamocolumnar junction, and then the metaplasia starts. So active metaplasia is maximum immediately after a few years after menarche, as well as after pregnancy. And these are the timings, or this is the time when the cellular unrest is maximum, and these cells are more prone for HPV infection. So this is the original squamocolumnar junction. Then we have columnar epithelium, and if columnar epithelium there is hyperestrogenism, whenever there is hyperestrogenism, even in a normal menstrual cycle, there will be some spread of the columnar cells here surrounding the external os. And then again the active metaplasia will take place, and again this advancing squamocolumnar junction will be approaching nearer the external os. So this process is going on continuously throughout the reproductive life. Nabothian cysts, which suggest a mature transformation zone, and another terminology for mature transformation zone is healed transformation zone. So at the periphery of the transformation zone, what I have shown it as a light blue color is a mature transformation zone, and dark blue is the advancing squamocolumnar junction, and active metaplasia is taking place. So in transformation zone itself, we have two parts. The peripheral part is healed transformation zone or mature transformation zone, whereas the part which is nearer the center, that is active part of transformation zone, where there is maximum uh, metaplasia which is taking place. Now these small openings which we can see are the cervical clefts, which are also suggestive of mature transformation zone. What is the starting point of CIN and how CIN spreads? CIN, now since our undergraduate days, we have been taught that this cervical cancer, especially it develops at the transformation zone. So that we know. But what is the starting point? So starting point is, it is always starting at the advancing or new squamocolumnar junction, where there is a maximum cellular unrest going on. So this is the starting point. Once it starts here at the squamocolumnar junction, then it spreads transversely in the transformation zone. It is spreading like that. It rarely crosses the transformation zone, and it is usually not seen. It is very rare to observe it crossing it and going to the ectocervix, whereas it is usually the whatever is the abnormal lesion, CIN remains limited to the transformation zone, where there are metaplastic cells which are more prone for the changes which they lead to the development of cervical intraepithelial neoplasia, and if remain untreated will go for even invasive cancer. Most severe CIN is always at this squamocolumnar junction, new squamocolumnar junction or advancing squamocolumnar junction, which is nearer the external os. Practical significance of this point is whenever we are taking a biopsy from, say, from this acetobite area, we can take biopsy from any place, but preferably it should be taken nearer the uh, part of the lesion which is nearer the new squamocolumnar junction, or which is nearer the external os, as compared to the area which is at the periphery. Cervical clefts and Nabothian cysts, these are the two important features which help us to identify or imagine where the original squamocolumnar junction must be. We need to, whenever we do the colposcopy and we see the cervix under magnification and we see the cervix as panoramic view initially, what we should focus on is this advancing or new columnar junction, whether we can see it completely. Secondly, we have to see where the Nabothian cyst and cervical cleft openings are seen, because that gives us an idea where original squamocolumnar junction must be. Reason is, this colposcopically there is no difference in this mature or healed transformation zone and the ectocervix. So for that these are helping us a lot. Identification of Nabothian cyst and cervical clefts, so that we can draw imaginary line that this must be the original squamocolumnar junction, and then we identify this area as complete as a transformation zone, and we can focus and see colposcopically to see whether there are any lesions in this area. Another interesting point is CIN is twice as common at anterior lip of the cervix as compared to the posterior lip, and it rarely develops laterally over the cervical ectos or lateral part of the transformation zone. CIN remains limited to transformation zone, and that is the reason it has a sharp external margin. Whenever it is a CI, underlying CIN, there is usually a regular and sharp margin. That is indicative that there is a cervical intraepithelial neoplasia as a reason of this acetobite area. Last class we have already seen screening of cervical cancer, and what to do if there is a abnormal screening result. So if there is abnormal screening result, when to go for colposcopy? That is what we have already seen, and this is a revision. So first screening test is primary HPV test. If it is positive and patient is non-compliant, we can go directly for colposcopy. But what is better is to do triaging, do HPV 16, 18. If it is positive for either 16 or 18, then go for colposcopy. If we are doing triaging with the cytology and it is showing anything as ascus or more severe than ascus, then to go for the colposcopy. If it is VI positive, VI is done as a triaging test and there are acetovite areas, then it's better to go with the colposcopy. If we are doing co-test, that is a combination of HPV test and cytology, both the tests are positive, we go for, again, we should be going for the colposcopy. If only HPV positive, cytology negative, then we should see whether it is 16 or 18. It is genotyping. If genotyping shows either 16, 18 positive, then we go for colposcopy. And if cytology is positive, whereas HPV test is negative, and anything which has H, that is atypical squamous cells where HSIL cannot be ruled out, or HSIL itself, high-grade squamous intraepithelial lesion on cytology, is a direct indication to go for colposcopy. If we are dependent on cervical cytology as a screening test, anything which has H is for colposcopy, whereas LSIL ascus, it is better to go for HPV test as a triaging, and if that is positive, then to go for the colposcopy. Or difference between ascus and LSIL is for with LSIS, we can directly go for colposcopy also. Any VI positive, and if colposcopy, you can refer the patient to a center where colposcopy is, scopist is available, colposcopy is available. It's better to do a colposcopy and then SOS biopsy, directed biopsy. So today's class is main focus will be on colposcopy because it is the mainstay of diagnosis of cervical intraepithelial neoplasia. A word of caution is colposcopy has tremendous interpersonal variability. The meaning of this sentence is, if you see same patient is seen by 2 or 3 different colposcopists, the report will be different with each. It is very, very subjective. And that is why so many efforts in recent years are being taken to make it as objective as possible. As a postgraduate student, it is very necessary for you to know about colposcopy, and as a consultant also, because there are so many now gynec practitioners who have dedicated their whole career only to do the colposcopy. So that field has exploded so much. There are so many new advances and there is so much of potential, and in a way it is also contributing to a social medicine also, because ultimately you are reducing number one genital cancer, which is still cervical malignancy in India. Colposcopy is an OPD procedure. It can be done on any day of menstrual cycle except with heavy bleeding days, menstruation, where visibility of the cervix will be a problem. But preferably it should be done, if possible, it should be done in follicular phase when the cervical mucus is thin. After ovulation, the mucus becomes thicker, and then you have to keep on cleaning it with the normal saline for more times as compared to the follicular phase. But still, it is not mandatory that it should be done in follicular. It can be done at any time, because always we should be looking for the compliance of the patient also. Colposcope itself, it is a binocular microscope with good illumination. It magnifies, and magnification is from 6 to 40. 40 times magnification can also be achieved. It has 3 parts: head, body, and light source. Focal length of the colposcope is around 30 centimeters. That is important. That means from the cervix, whenever we are looking at the cervix with the colposcope, the distance between the cervix and the scope should be around 30 centimeters. Video colposcope has display facility. It is very good. Video colposcope is a good one, and whenever I have done in my career colposcopy, I have done it with the video colposcope. It has a good display facility so that you don't have to look through the eyepiece with your eyes. You get a image and you can see the display, and then many at a time more than one person also can see the display. It also has a LED light and a control panel. On the control panel, there are various buttons are there, so that there is a green filter option. Magnification can be increased or reduced. Then there is a option of manual focus or auto focus, and even timer on and off options are there. All these are on the control panel, which is in our hand. On the trolley, we need to have self-retaining speculums, cusco speculums of all sizes. Sponge holding forceps and cotton swabs are to be there. Cervical punch biopsy forceps should be there, and remember that it should be sharp. Maintenance of this sponge biopsy forceps is very important. As with continued use, it can become blunt. When it becomes blunt, then the destruction of the cervical tissue is more when the biopsy is being taken. A larger area gets affected and patient gets more pain, and that is the reason it should be kept always. It should be sharpened intermittently, and we need gloves and normal saline. We need acetic acid on the trolley, and it should be 3 to 5%, preferably it is 5% whenever we are doing colposcopy. It should be freshly prepared. So remember that whenever we have acetic acid 5% bottle on our trolley, and if we are using the same for many days, that itself might be the reason why we are not getting acidomite areas. That means the efficacy will be lost. That is the why it is recommended that you prepare it on daily basis, how or intermittently, at least after every few days. So what the proportion is, you take this 95 ml of water, either it can be distilled water or 20 minutes boiled water, and add 5 ml of glacial acetic acid. Now, whoever is preparing it should remember that glacial acetic acid is very strong. It can burn the skin also. So it needs to be handled very carefully. It needs to be labeled and kept away from the trolley so that there should not be any accident. Lugol's iodine, how it is prepared is, you take 100 ml of water, distilled or 20 minutes boiled water, add 10 gram of potassium iodide, 5 gram of iodine crystals. Even our pharmacist also can prepare this Lugol's iodine for us. Once prepared, it is good for 1 month. That means after 1 month, we need to write the date of preparation on the bottle, and after 1 month we need to discard the remaining and take a new one. We need a gynec examination table, and preferably the table where we can also give a lithotomy position. So either you can do it in dorsal if patient is very cooperative, or a multiparous patient or a slight cervical descent, then dorsal position is okay. But otherwise there is a problem with the visibility, then it is better to have a lithotomy position whenever we are doing a colposcopy. There are portable and non-portable or wall-mounted colposcopes which are available. There is an endocervical speculum which goes by the name of Kogan. Kogan endocervical speculum can be used to visualize the endocervical canal, and if it is not available, we can simply use a long non-tooth forceps to visualize the endocervical canal. For biopsy, we need punch biopsy forceps, and for arrest of bleeding, Monsell's solution or paste is applied, or silver nitrate solution is applied, and both are not available. Then a constant pressure over the area after a few minutes leads to the control of the bleeding from the punch biopsy site on the cervix. Endocervical curate we should have. Formaldehyde, 10% formaldehyde or formalin we will be needing to send the biopsy sample. And whenever we are doing in the same room or in the same setting, we should have the facility for the treatment also. Treatment can be either excisional treatment or ablation treatment. For excisional treatment, what we do is a long loop excision of transformation zone, that is LEES, and another name for the same procedure is loop electrosurgical excision procedure, that is LEEP. So LEES or LEEP if the facilities are available, or if facilities are not available and we have to go for ablation treatment, equipment for cryocauterization and electrocauterization should also be available. Steps of colposcopy. Initially, we should go for a panoramic view of the cervix after exposing the cervix with the speculum. And usual magnification which is used is 6 or 8 times magnification for this initial impression about the cervix. That is called as a panoramic view. One has to then apply normal saline to remove all the mucus, and we remove the mucus. Usually the squamocolumnar junction is visible. We should be identifying the external os and squamocolumnar junction. Hence onwards, whenever I will be commenting about squamocolumnar junction, it is always about the advancing or new squamocolumnar junction, which is near the external os. After cleaning the cervix with the normal saline and identifying the squamocolumnar junction, next step is to go for the green filter and if necessary to increase the magnification to see for the vessels. So here we have to see vascular architecture, whether it is normal or abnormal. That is also another advantage of colposcopy. Under magnification, we can pick up the abnormal vascular architecture, and that helps us to pick up the area for the biopsy. Then we should switch off the green filter and switch on the timer so that we apply copious amount of 5% acetic acid. It should be applied for complete 1 minute. Intermittently, we should be looking whether the acetoid areas are developing or not. If acetoid areas are developing, what we should be noting is the location. Is in the transformations or outside the transformations of how much is the size of the acetoid area as compared to the total cervix in percentage, and how whether it is densely white or it is milky white or it is transparent, and how are the margins, whether sharp margins are there or whether it is a diffuse acetoid margins are diffuse, that we have to see. Once acetoid effect goes off, again we should focus on the abnormal area wherever acetoid lesions were present, and in those areas again we have to see for the vascularity with the green filter, because whenever we see for the vascularity, the main significance of vascular architecture is at the sites wherever there are abnormal areas or lesions present. Then we should apply Lugol's iodine and note the pale areas. And we should document as per IFCPC 2011 nomenclature, and we should note the SWIDI score. What is this? IFCPC is International Federation for Cervical Pathology and Colposcopy. Remember this long form. International Federation for Cervical Pathology and Colposcopy. They have provided us with this 2011 colposcopy nomenclature, which is being used all over the world at present uniformly. The main aim of that 2011 colposcopy nomenclature, IFCPC nomenclature, is to make it as objective as possible, so that interpersonal variability is reduced if we go systematically as recommended by this. So how they have divided it, how we documentation of colposcopy in 5 compartments. First is general assessment, second about normal colposcopy findings, third is about abnormal colposcopic findings, fourth is about if whether there is a suspicious area for invasion, and last is miscellaneous findings. So these are the 5 headings under which we need to do the documentation whenever we are doing any colposcopy. For postgraduate students as well as consultants, I request that you follow this 2011 IFCPC recommendation. It really helps for the systematic way we do and document the colposcopy. In the general assessment of this IFCPC 2011 recommendation, in the general assessment, there are 3 points. First is whether the colposcopy is exposure of the cervix is adequate or inadequate. If the cervix is not seen adequately, if there is inadequate exposure or visualization of the cervix, then we have to mention the reason also, whether there is bleeding, whether there is infection, inflammation, any scarring in the vagina, whatever is the reason, or atrophy of the vagina, that we have to mention whenever there is an inadequate exposure and visualization of the cervix. Then we have to comment about squamocolumnar junction visibility, whether it is visible completely, partially, or not visible at all. So again, as I said, whenever we are talking here in this guideline about squamocolumnar junction, we are talking about the new squamocolumnar junction or advancing squamocolumnar junction, which is nearer the external os. Then we need to comment about type of TZ, whether it is type 1, type 2, or type 3 transformation zone. So what are these three types? Type 1 is where the transformation zone is completely on the ectocervix and it is visible completely. Type 2 is where the transformation zone has extended partially or completely into the endocervical canal. In type 2, though it is in endocervical canal, it is still visible completely. Whereas in type 3, it has advanced into the endocervical canal to such an extent that complete visualization is not possible. That means we are not able to see the squamocolumnar junction because it has this uh, transformation zone has advanced in a great way inside the endocervical canal, which will be seen in the elderly women after the menopause. So that is type 1, type 2, type 3. Significance of dividing this transformation zone in three types is it is important for the especially about adequacy, whether the colposcopy is adequate or not, to comment on that, as well as treatment point of view. Whenever we want to treat, the area which is nearest the external os or which is at the advancing squamocolumnar junction, because here the uh, possibility of having a severe CIN will be maximum. But if it is not visible, we cannot treat it also completely, and that is why type 3 will not be properly evaluated as well as treated as compared to type 1 and type 2. That is the significance of dividing transformation zone in these three types. Now, certain findings in the colposcopy are labeled as normal findings, such as we look at the ectocervix and comment whether the original squamous epithelium is mature or atrophic. In elderly women, postmenopausally, it might be atrophic. Then columnar epithelium, either is ectopy. Ectopy is where the columnar epithelium is advancing and surrounding around the external os. That is ectopy. Then we see for the squamous metaplasia epithelium and then we identify the mature transformation zone by presence of Nabothian cyst and crypt openings. These are normal findings. Presence of Nabothian cyst is normal finding. Crypt openings is a normal finding. And in pregnancy, what is happening is there is decidualization of the stroma of the cervix, so that we get some plaques or raised areas, and that is also normal finding in pregnancy if we are doing colposcopy during pregnancy. In the abnormal findings, these are divided in three groups. We have to comment in three ways. One is general principles of related to the abnormal findings or lesions. Second is whether the lesion is to grade it, whether it is grade 1 or grade 2. And third is whether there are associated non-specific findings present, such as leukoplakia, erosion. These are also included in abnormal colposcopic findings. These are abnormal, but these are non-specific in the sense that these are not the malignant lesions. These are not suggestive of CIN. In the general principles, two things whenever we see, or suppose we get this acetohide area, then what we need to comment about is its location and the size. Location is as per the clock. Imagine here it is 12 o'clock and here it is 3 o'clock, 6 o'clock and 9 o'clock, and accordingly we have to comment about that. and whether it is in the transformation zone, outside the transformation zone. So this broken line is imaginary line where the original squamocolumnar junction was present, depending on presence of Nabothian cyst and cryptocoels. And to comment about the size is how much of the percentage of the cervix it must be occupying, or how much in quadrants also it is occupying. So this example is AW lesion is acetovite lesion, and it is in the transformation zone. This is an example. It is from 12 to 3 o'clock position. It is occupying 25% of the cervix, or it is present, it is affecting 1/4 quadrant. So these are the four quadrants, quadrant 1, 2, 3, 4, out of which it is affecting one quadrant completely. That is why we say it is 1/4 quadrant. It would have been half, we would have said 1/8 of the quadrant of the cervix is getting affected, and so on. Or if it is completely affecting this number 1 quadrant also and number 2, then it is 2/4 quadrant have been affected by the acetovite lesion. So this is how we should be describing the abnormal whenever there is an abnormal finding, especially whenever there is an acetovite lesion. How we grade this is, for grade 1 is minor, grade 2 is major. So acetovite lesion, if it is a thin transparent epithelium, it is minor. If it is dense white, then it is major. If the border is irregular, it is minor. If it is a sharp border, regular border, it is major. If it appears gradually, it is minor. If there is a rapid appearance of acetovite area, it is major. And we look for the presence of mosaic and punctations. Presence of fine mosaic and punctations is minor, whereas coarse mosaic, coarse punctations is suggestive of the major or grade 2 lesion. Other features of grade 2 lesion are ridge sign and inner border sign. These are the two new emerging colposcopic signs. This is a grade 2 or major lesion if there is a presence of ridge sign. Meaning of ridge is at the top, like a roof of the house. So if it is elevated, then it is called as if it is raised as compared to the other surface of the cervix, then we call it as a ridge sign. And if it is a ridge sign which is a dense acetovite area which looks to be slightly raised as compared to the surrounding area, it is suggestive of a major lesion. Inner border sign is where it is said there is a presence of a lesion in lesion. That means remaining acetovite area is not very dense. It is transparent. But there is an area where there is whitening is becoming dense. Then we call it as a inner border sign. In other words, there is a dense area in the transparent area. There is a large acetovite area, but in that large acetovite area, there is a small area which is dense acetovite, which suggests that here there will be presence of a severe CIN. Then it is called as a inner border sign. Where you remember that lesion inside a lesion, then you call it as an inner border sign. These are the two new colposcopic signs, which are both of which are suggestive of a severe degree of CIN. So these are considered as features of grade 2 lesion or major lesions. Fourth is suspicious of invasion. Whenever we see abnormal vessels or a growth over cervix, ulcer over cervix, there is a bleeding on touch, and there is abnormal surface contour. All these are features suggestive of invasion. Normally, the normal vessel, there is a regular branching, and as like a tree, the branches become thinner towards the end. So this is regular. Whereas abnormal, there is absence of branching, abrupt ending of the vessel, and again it restarts, and the vessel at some areas there is a like a knobbing, it is thin and thick areas are present. All these are suggestive of abnormal vessel and suspicious for invasive cancer of the cervix. And miscellaneous is presence of condyloma, cervical polyp, or where cervical endometriosis is documented under the heading of miscellaneous findings as per this IFCPC 2011 recommendation. Colposcopically, we look at the acetohyte area, we look at the cervix under magnification, we identify the squamocolumnar junction, we identify the original squamocolumnar junction, we look at the transformation zone uh, entirely. But what is very important, another advantage of colposcopy is we can see the vascular pattern. This should always be done before application of acetic acid. When we need green filter for that, and magnification also needs to be used to see for the fine vessels. We should be looking for the vessels again after the effect of acetic acid goes off. The reason is that means we should see for the vascular pattern twice. First, before application of acetic acid, and secondly, after the acetic acid effect goes off. Vessels are not clearly seen when the acetic acid action is present. So in acetohyte area, there is a vascular architecture cannot be seen. Vascular pattern at abnormal areas has significance. Why we have to look at it twice is, first is we are looking at the vasculature uh, before application of acetic acid. But secondly, whenever we apply acetic acid, we get a acetohyte area, we should focus on that area only and see how the vascular architecture is present in that area, because there is no significance of vascular architecture at normal areas of the cervix. This is the important concept, that even if you see abnormal vascular pattern in the normal area, it has doubtful clinical significance. So that is the reason we need to focus on the areas which we have identified as abnormal after applying acetic acid. And once the acetic acid effect goes off, we need to focus and magnify and see again. If we see, like here we can see that at from 11 to 12 o'clock there is a acetohyte lesion. So we will be focusing in this part of the transformation zone only to once the acetic acid action goes off. And if we see coarse mosaic pattern or we see coarse punctation, that means the vascular architecture is abnormal, which suggests that there is a coarse punctation, coarse mosaic, that is indicative of a major or type 2 lesion, and we need to take a biopsy from this part. Wherever we see the mosaic, from that part, wherever we see the punctations, we have to select that area for biopsy. That is the significance of going back to vasculature after the acetic acid effect goes off. This IFCPC 2011 also suggests that we should be documenting the colposcopic findings by drawing a diagram, and I wanted to show you how they have recommended, and I have already written the instructions here, and I will try to draw the diagram as recommended by them. So first it says that you draw the two circles. The outer circle is suggestive, just a minute. The outer circle, it is the cervix which we can see. And we are focusing on the this part of the cervix, whereas inner circles is of the external os. So these are the two circles we have drawn. We have to create the four quadrants of the cervix by drawing these two perpendicular lines, so that we have this quadrant as number 1, this is number 2, this is number 3, and this is number 4. Then wherever lesion is, we should be drawing the lesion like that. So now you see that I am drawing this is the acetohyte lesion. Then if it is an acetohyte lesion, then I will be labeling as AW. Once the effect of the acetic acid goes off, I will focus here and see whether there is how is the vascular architecture here. If I have observed that there are coarse punctations, then I will label it as P, that is punctations, this area. Suppose I see the punctations here. Then if there are abnormal vessels, I have to label it as AV. And if whenever I will be applying Lugol's iodine, I have to even demarcate the area which is showing the iodine negative. So that will be seen as yellow area, and I have to label it. Suppose this is the area, I will have to label it as I. I is iodine negative. Then from wherever I decide to take a biopsy, I have to mark it like that. So that I will be marking it like this as a cross. Or this is the area from where I plan to take the biopsy. So this is the correct documentation of abnormal wherever lesion is present, how much is the size, what from which clockwise also where the lesion is, with respect to external loss where the lesion is, which quadrants it is affecting, whether there are associated punctations or mosaics, whether abnormal vessels are there, and where is the iodine negativity, and which is the site from which I plan to take the biopsy. That will be the complete diagrammatic. This is the complete diagrammatic documentation of our colposcope. Then we go for Swedish score, and if postgraduate students you are asked, it should be at the tip of your tongue. What 5 features are included in the scoring of the colposcopy? Swedish score. 5 features are: first is aceto uptake. How was the acetohyte area? Whether there was no uptake or it was transparent, whether it was milky or dense opaque. Accordingly, we give the score. Then how is the margin of the acetohyte area? Diffuse margin is normal. Sharp irregular margin is score of 1. Sharp and regular margin is worst. So it gets score of 2. In the vessels, fine vessels might be normal. If abnormal vessels are there, then the score of 2. Then lesion size less than 5 mm is 0 score 6 to 15 1, and more than 15 millimeter is 2. And we have to see for iodine uptake. Brown 0 score, patchy yellow 1. If completely it shows yellow, then the score of 2. So this is how we have to score the abnormal. By the Swedish score, we have to do the scoring of colposcopy. Score of 0 to 4 suggests normal or CIN1. 5 to 6 is CIN2 or 3, whereas 7 to 10 indicates either CIN3 or invasive carcinoma. This you need to memorize these 5 main features which we use, and how the scoring is done as 0, 1, 2. Maximum score is 10, minimum is 0. Now, after documenting, as per IFCPC, we have to document, we have to draw a diagram, we need to score our colposcopic findings by Swedish score, and then at the end, this is the last step, we need to commit ourselves and write the provisional colposcopy diagnosis. We don't do the diagnosis and just comment there is acetohyte area and move on. No, we need to comment about our impression also, and then correlate it with histopathology, so that, or discuss it even with the histopathologist, so that with better communication between the colposcopist and histopathologist, then consistent results are there. There is less possibility of mistakes on both the sides. So either it can be normal. There is a terminology which is called as SPI, where there is a suspicion of papilloma virus infection, SPI, or condyloma. Then LSIL, low-grade squamous intraepithelial lesion, features suggestive of LSIL. Features suggestive of HSIL, high-grade squamous intraepithelial lesion. Features suggestive of invasion, squamous cell carcinoma. Then features suggestive of endocervical canal, especially adenocarcinoma in situ, or having a adenocarcinoma itself. That should be our provisional diagnosis, one of these in this list at the end of colposcopy. Then when we take the biopsy, either colposcopy directed or as a VIA, if colposcopy is not available, it should be taken near the squamocolumnar junction or external os, end of the lesion, because here the CIN is most severe. Whenever there is acetovite area or iodine pale area, then its end, which is nearer the external os, that should be the site selected for biopsy. We should be taking first the biopsy from posterior lip lesions so that these lesions are not obscured by the bleeding, which starts when if we first take the anterior lip. So first finish off biopsy from the posterior lip abnormal areas, then move to the anterior lip. We should be biopsying most abnormal areas. That means the area which has denser acetovite lesion, which is most yellowish by Lugol's iodine, which also shows coarse punctations or coarse mosaic pattern or abnormal vessels. These are the sites which are to be selected for biopsy. We should label the location as per the clock position. Multiple biopsies are to be sent in multiple bottles. Then endocervical curettage need not be done along with each colposcopy because it produces more discomfort for the patient. Specific indications are there, then only we have to go for endocervical curettage, such as if transformation zone is type 3. Type 3 is where it has gone in the endocervical canal partially or completely and it is not completely visible. Or if there is a glandular abnormality on cytology, then we have to take the endocervical curettage. What are the advantages of colposcopy over VIA, visual inspection, after application of acetic acid? Is we have better light, we look at the cervix under magnification, and most important, we can study terminal vascular architecture so that it also gives us a chance to give a permanent record to the patient, because whenever she comes for follow-up and that record is there, it helps a lot. False positives are less and less unnecessary interventions with the colposcopy as compared to VIA. Thank you so much. These are the references. There is an atlas of colposcopy principles and practice which is available on internet, and it has videos also, and it is very useful. And for postgraduate students, I request that you once you visit and go through it. And second is our Novax Gynecology 2019. Thank you once again.